Hi, good morning. My name is Meheshinder Singh. I'm a consultant, general and colorectal surgeon based here in Pantai Hospital, Kuala Lumpur. So I usually start my mornings by doing my ward rounds, and these can be rounds or visiting patients who can be inpatients in the ward or even patients in the either intensive care unit or the high dependency unit. Yeah, but today being a Friday, it's a little different because Fridays are the day mornings where we have the MDT meetings or tumor board meetings or cancer board meetings, wherein we discuss complex cancer cases. It need not be just colorectal cancer cases, it can also be gynecological cancers, breast cancers, or urological cancers, wherein we have a combined meeting with even the pathologist, the oncologist, the surgeons all put together, where we put all the heads together and decide what the best mode of approach would be. All right, I'll see you in a bit then. So this is the intensive care unit now. I had a patient, a 92-year-old gentleman who presented with small bowel obstruction. So we did a laparotomy and did a segmental bowel resection, and he's doing pretty okay as well. So I think it's good enough probably to be transferred back to the general ward. So intensive care essentially just entails basically monitoring people who had been subjected to major surgeries, who require more critical monitoring. So let's move on to the general wards now. A gentleman who's got a low rectal cancer and who's planned for surgery this evening. In most circumstances, we can get away with what's called a sphincter saving procedures and basically preserving the continuity of the bowel and not giving them a permanent bag. But unfortunately, this is one of those rare cases where we are unable to do that because he's got a very low-lying tumor going right down to almost close to the anal verge. So he has to have a resection with a permanent colostomy. Yeah. So part of the work also entails doing endoscopes. Can be a form of both upper and lower GI endoscopes. Primarily, I do more of lower GI endoscopes, being a colorectal surgeon, obviously. So we start off basically by doing what's called a timeout. All right. Now, this is a very good practice where we ensure that we got all the details of the patients correctly addressed. Again, it's all teamwork. It's not just me alone. It's me working with the endoscopic trained nurses who make this procedures possible. So what we do essentially is procedure-wise, we put them under short sedation, which entails giving them a concourse of some medications per se. So we're going to start off with the first procedure. Now this is a young lady who's presented with features of upper abdominal discomfort and bloatedness, more dyspeptic symptoms and altered bowel habits and bleeding per rectum. So she's going to have both an upper as well as a lower GI endoscopy. All right, so we're done with the upper GI endoscopy. Another one to go afterwards, and then we'll see what that shows. So essentially, that's how endoscopy works. It's a multidisciplinary kind of thing again. It's teamwork. I think probably let's just put a stop to visualizing my scope experience for the day and maybe join me in the clinic afterwards. Yeah. So I'm still practically just about a quarter way through my clinic. I've got at least about 18 patients lined up to be seen today. It's going to be pretty much of a long clinic day, and what I thought of probably will just stop here. So this is a scheduled elective surgery of a patient who's got a very low-lying rectal cancer, which requires an abdominal panel resection. So, and we'll be approaching this through a laparoscopic approach, a keyhole approach. So I'll run through the process as we move along. So I'm going to start off by scrubbing in, and we'll take it from there. All this entire process is all a teamwork, and even though we as surgeons we play an important role, but nothing's possible without the help of the entire team of people who we work with. The insufflation is taking place. As the start of the procedure, we do what's called a complete laparoscopic assessment, where the camera goes in just to evaluate, inspect the entire abdomen. So in cancer surgeries, we look out for things like if there are any other, occult cancer deposits that were not seen on the scans, for instance, that we may visualize under laparoscopy. Now, saying one of the most crucial steps essentially is ligating the main pedicle here, with the main vessels, right? We've done that. And once you get in the right plane, just separate the bowel. And they call it the avascular plate, but you shouldn't be encountering any blood vessels, so it's very clean. Scissors. Gauze cut back. So the surgery apparently took a bit longer than usual. It was quite a bulky tumor, which is why it took a bit extra time. So generally after the operation, I always like to meet up with the family and just, discuss and let them know, assure them that everything's done and, he's stable as well. And he's going to go back to the high dependency unit. And we'll just observe him for a day or so before we transfer him back to the general ward thereafter. So what we need to do essentially is, after removal of this entire surgical tissue, we're going to send it off to the lab for histopathological assessment, and we'll have the report within another 3 or 4 days thereafter. So all right, okay, so post-procedure, basically we'll sit down and just have to spend a bit of time writing the operating notes and the operating orders hereafter. Yeah, we've come to almost the tail end of the day, and we just finished one major long case, and I've got another short case to proceed hereafter. Following that, I'm going to end up my day by doing my clinical rounds again, one more time, the night rounds, before I head back home. Colorectal cancer, it is a major public health concern today. It is currently the second most common cancer in this country. And sadly, most of the patients that we see today are those who present in the later stages of cancer, which is why we always stress on the importance or significance of early detection and the importance of screening. If you are 45 years above, and please do come forward and have your test. If you can, get a colonoscopy done, well and good. Otherwise, even an FIT would be a good substitute to a colonoscopy. With that, thank you again, and a very good evening.